1 in 3. That's how many American men will face physical violence, sexual assault, or stalking by an intimate partner. 1 in 3 women worldwide will endure physical or sexual abuse, most often by someone they know. But domestic abuse isn't just bruises. It's manipulation, it's fear, it's control that seeps into every part of your life. I'm Ingrid Dutton, and I survived it. Then I created 1 in 3 so no one else has to suffer in silence. Each week, we break that silence together. Occasionally joined by survivors, loved ones, and experts, we talk about the pain, yes, but also about the healing, resilience, and the fight to reclaim your life. This podcast is more than awareness, it's a lifeline. And a reminder, you are seen, you are heard, you are never alone. Search for 1 in 3 wherever you get your podcasts, because every voice matters and every story deserves to be heard.
According to UNOS.org, as of March 31st, 2022, there are 106,274 people waiting for a transplant. This includes men, women, and children. OrganDonor.gov states that another person is added every 9 minutes to that list. There are 17 people who die each day waiting for an organ transplant. 2021 marked a record-breaking statistic, with 20,401 donors, which led to 41,354 transplants. April is designated as National Donate Life Month in order to raise awareness about donation. April 6th, 2022, which is tomorrow, is Donate Life Living Donor Day. Good morning, Jessica.
Is it? Good morning, sister.
Is it? I'm Ingrid.
I am Jessica. This is another situation.
And what a situation we have today.
Goodness gracious, people. We've talked to so many people for this week's podcast and got so much good information.
Yes. So, like we said in the intro, April is Donate Life Month. And today we're going to talk with somebody who needs your help. And she's one of the thousands that are needing a transplant. And she has been gracious enough to share her situation with us. And following that, we got to discuss with a bunch of very fun ladies.
Medical professionals.
They are transplants, varying positions in transplants. So Jessica.
And another donor story mixed in with that.
Yes. So Jessica, did you know that kidneys have the longest wait list to get a transplant?
I did not.
There are approximately 93,000 people on the wait list right now.
So many people.
Right. So without further ado, let's talk to someone who needs one of those.
Okay. Jessica, Jamie,
Jessica. Nice to meet you.
Hi. It's nice to meet you. I guess, do I just start with telling why I'm on here? What I'm doing? Okay.
Yeah.
So I have bilateral polycystic kidney disease, which is an inherited disorder in which clusters of cysts develop in the kidneys, causing significant enlargement of the kidneys and eventually kidney failure. A typical kidney is the size of a human fist, whereas a PKD kidney can be as large as a football and weigh up to 30 pounds each. At this time, there is no cure for PKD. And in the last 5 years, there was a medication approved by the FDA to slow the progression of the disease. And I was actually in a few of the drug studies that helped approve that drug. PKD patients are often told that they'll develop symptoms between the ages of 30 and 40, and that kidney failure is usually between 50 and 60. I inherited my PKD from my biological mother. She has 3 biological children, and of the 3 of us, 2 of us have the disease. Typically with PKD, you're also told to look at your parent as the projection of how your disease will progress. My birth mother is currently on hemodialysis, and she is listed at 2 different transplant centers and in need of a transplant. And she is in her mid 50s, I believe, whereas I'm 35 and I need a transplant now as well. And the reason that I need a transplant now is because I have PKD1 gene, which is a more rapidly progressing form of the disease. And the way that I even found out that I had this disease, when I was 16 years old, I decided that I really didn't want to go to school one day. And my mom was out of town. She was actually in a different state taking care of her mom who was sick. And I had an aunt that was at home with me. And I called my mom and I made up some big elaborate story that my stomach was hurting and I just absolutely could not make it. And my mom, in her true nature, said, if you are that sick that you can't go to school, then you're sick enough to go to the doctor. So I schlepped myself to the doctor the next day, continued my lie at the pediatrician's office because I did not want to get in trouble. And my pediatrician, who was just this amazing human being, believed every word I said. She just took it and thought, oh, she must not be feeling well, and sent me for an ultrasound to see if my gallbladder was acting up. And I think it was the next day, actually, that I was fit in to do the ultrasound. And my mom was still out of town at the time. And I remember going in, and there were 2 people in the room with me. And my aunt was actually out in the waiting room, but I was by myself back in the little room where they were doing the ultrasound. And when they started, they were just kind of making small chit chat with me. And one of the girls stopped on one part of my abdomen, and she looked at the other lady and she said, look at the screen. And I looked, and of course I didn't know what I was looking at. I had no clue what they were talking about. And then they asked me, do you have a family history of kidney problems? And I didn't know of any family history of kidney problems. So I said, no, not that I'm aware of, and kind of went about my business. And they had been going back and forth with me, just very small talk, but very sweet and kind and just kind of joking. And it was when they had focused on a certain area of my abdomen that they no longer were making this small talk with me. And they just kept like pressing things. And I remember seeing them measuring it and moving it. And I knew then something wasn't right, but I didn't know what. So when I left the room, I went to my aunt and I said, I think something's wrong with my kidneys, because they asked if we have a family history of kidney problems, which my aunt just kind of brushed off because she didn't think much about it. And we went about our business. And it was about 1 or 2 days later that I was called into my pediatrician's office. And my mom was still out of town. So my mom told me to go ahead and go to the appointment, and that if I needed to call her, I had my cell phone, I could call her and put her on speakerphone. And my pediatrician, who again was just a godsend of a human being, sat down and she kind of went over like everything that had happened with the ultrasound. And I'll never forget, she was the most put together human being. And she was so nervous talking to me, and she seemed scared to talk to me. And she took a Post-it note and she drew a picture of a kidney. And she said, this is what a kidney looks like. This is where your kidney is located on your body. This is what your kidney does. And just kind of gave me a rundown, like a very quick educational lesson of how your kidneys work. And then she drew another kidney beside it, which was a PKD kidney. And she drew it with numerous cysts on it. And she said, explained what it was. And that's how I found out that I had PKD.
Wow.
And it was through that little Post-it note that she had made for me, which I knew that she was doing that to help me at 16 years old understand what was being told to me.
And you were by yourself?
I was by myself, yes.
Oh my gosh.
Yep.
And feeling fine though, right? You had made up the stomach ache to just not go to school.
Oh yeah, I was fine. I had nothing wrong with me whatsoever. So it kind of proves me wrong for trying to just get out of school. But I felt fine. And I think one of the cool things about being diagnosed so young, I was so young that I was so naive, and I didn't really realize the weight of what was yet to come. But I also was educated immediately by my doctors on what to expect. So I always knew what was going to happen. So where I'm at right now was never a shock to me that this could happen. And for the most part, I've always been able to put my disease on the back burner and not even think about it, which has been a wonderful thing. It's not like it's played a significant role in my life that every single day has been dictated by this disease. And so after I was diagnosed by my pediatrician, she had my mom come in when my mom got back into town from taking care of her mother, and said that she needed to take me to Emory because they had a whole area of Emory dedicated just to my disease. And at the time, there was still very little about my disease that anyone really knew. I mean, I had never heard of it before. And so I started at Emory, and I started doing clinical trials there and just different studies at 16 years old.
Wow.
And at the time, you couldn't do a drug study at 16, but you could go and be admitted into the hospital for a few days. And it's in kind of like the basement of Emory is what I would call it. And it's where they do their research studies. And you go in and you're admitted for a few days, and it's just regular hospital rooms. And then they run numerous tests on you trying to learn more about PKD and how the disease works. That was where I found out which gene mutation I had. I was a part of the study that actually determined that there were 2 different types of PKD genes other than like the autorecessive and the type that I have. And I did those studies from ages 16 to about 20. And then from about age 20 to 24, I just kind of lived a normal life. I no longer really was doing any studies with Emory. I didn't have a reason to do them. And I ended up getting pregnant when I was 24. And I had my daughter at 24, and she was born at 35 weeks due to complications because of my disease, which thankfully she was healthy and has done very, very well. And it was about 2 years after giving birth to her that I started to have pain in my left kidney, which is kind of like my problem child kidney. It's always the one that causes me problems. And so I went back to Emory, and they did a cyst aspiration, which is they went into both of my kidneys because both of them had enlarged cysts ranging up to 10 centimeters in size.
Oh my goodness.
And they went into both kidneys with a needle, and they pull the fluid that is in your cyst out, and then they inject the cyst with an alcohol type solution to dry up the cyst to help prevent them from continuing to grow again. And when I had gone in to do that, my doctor at the time, who is one of the top PKD doctors, her name is Dr. Arlene Chapman. She actually started talking to me about doing the clinical drug trials that they were doing for a drug called tolvaptan. And I really didn't feel anxious about doing it, knowing that my disease is genetic and that it was something that I could possibly pass on to my child. I was more than ready and willing to try it if it could help her in the future, if unfortunately she were to ever deal with the disease. So the criteria was I had to wait 6 months post cyst aspiration before I could start the trial, which I did. And then from age 26 to about age 30, I think about age 30, I did a few different tolvaptan drug studies. And that did help. It did help reduce the size of my kidneys at the time. But once the drug went for FDA approval, I actually came off of the drug. And it's not the easiest medication to work a full-time job on. And it just did not seem very realistic at the time with what I was doing to be able to sustain working full-time and being on the medication. So I chose not to be on it because my GFR was good. I felt good. I didn't really see a massive need at that time.
Is it because of the side effects? Is that why you can't do? Okay.
Yeah. And the side effects are not really this major problem, but a lot of it is you have extreme thirst, which makes you also have to use the bathroom constantly. You're up maybe 8 times a night. You are in the bathroom at least every hour.
Goodness.
And it all depends on what dose that you're on. And you kind of can train your bladder to give you maybe like an hour and a half, but you're lucky to get past an hour and a half without having to be in the bathroom. And when you're in education, that is very hard to leave to go to the bathroom.
Right.
So it just didn't seem realistic at the time. But I was doing very well for quite a while. And it was in the spring of 2019, when I was 32, that I started my major decline. So this is when everything kind of went from, I really never thought much about my disease other than being in the clinical trials and kind of that back and forth of my check-ins with Emory, to everything became centered around this disease for a while. And what happened was, in the spring of 2019, I started experiencing episodes of blood in my urine and severe flank pain. And I had had blood in my urine previously, but I had actually never really experienced the flank pain unless I had dealt with a kidney stone. But when you have PKD, some of the side effects that can happen are you have cysts that rupture. And typically when I've had a cyst rupture, it's actually not a painful thing for me. It wasn't until much later in the progression of my disease that it did become painful. And another thing that you can have happen is you can have a hemorrhage inside of the cyst. And what will happen is there's bleeding within that cyst, and the cyst wall will expand rapidly, and that will cause some of the worst pain I think I've ever experienced. And of course, you can take pain medications for this stuff, but most of it is prescription. You can't work like that. You can't really function like that. You can't take ibuprofen. You can take Tylenol, and you can use a heating pad. And because of that, I actually have a heating pad at home and I have a heating pad at work. And that is what wraps around me when I go through those times. But when I started the initial severe decline, I started experiencing the blood in my urine and the severe flank pain. And I had blood in my urine off and on throughout the years, but it was nothing major. But I kept experiencing repeated episodes of this bleeding and the pain. And I knew that something didn't feel right and that something was happening that I just couldn't pinpoint what was causing it. So I actually had a local nephrologist that I went to, and they told me that this was a normal part of PKD, and all PKD patients have blood in their urine and they have flank pain, and kind of sent me on my way. And that went on for a few months, where I kept going back and forth because I kept having these repeated episodes every few weeks. And I knew that I had experienced that in the past, but I also knew that it stopped and it didn't come right back. And in May of 2019, I started experiencing an incredibly deep, almost paralyzing pain in my left kidney. And I reached out to the nephrologist office again. And at that time, I spoke with the nurse at the nephrologist office. And she said that the nephrologist said that if I was in that much pain, I should go to the ER or follow up with my local PCP. And I remember sitting there just ready to scream and cry all at once, because I knew if I went to the ER, they would ask me why I didn't go to my nephrologist. And I knew if I went to the PCP, they would ask me why I didn't go to my nephrologist, especially since I was established with a local nephrologist. And realistically, when I think of going to the ER, I know that it's going to be a short-term relief because they can maybe give me medicine, but it's going to take a urologist or a nephrologist to really help me dig into what's going on. And I know that. And I attempted to argue with the nurse, and she said, I do not know what else to tell you except to go to the ER or follow up with your PCP. Wow. Thankfully, I did go to a local ER, and the local ER told me I should go to my nephrologist, especially since I was established locally. But I also stopped experiencing the pain and the bleeding shortly after that main incident. So thankfully, that wasn't much longer that it had gone on. And then I think I had about 2 months where things were pretty calm. And I think it started again in July, but it was only for a week or so. And then it happened again in August for like another week. Again, my gut kept telling me that it shouldn't happen like that, but I knew that I had gone back and forth so much that it wasn't going to get me anywhere to argue about it. So I just tried to ride it out the best that I could. And then in October of 2019, I started to see significant amounts of blood in my urine once again, but this time the blood looked different. And once the bleeding started, it didn't stop for a month and a half. And it also, I started having severe flank pain that didn't stop for a month and a half. And so I went back to my local nephrologist, and it was the repeated back and forth of, this is just what PKD is. You're going to always have blood in your urine. You're always going to have flank pain. There's nothing that we can do to help that. And I felt at that time like I was nuts. I felt like, if this is what PKD is, why did nobody ever forewarn me it was coming? I had been at Emory for years, and I had an amazing pediatrician who had educated me on this disease. Doctors at Emory had educated me. Nobody told me that this was going to be my everyday life. Why didn't they tell me this? And so one night I was in pain beyond belief, and I was frustrated, and I felt like nobody would hear me. So I sat down at my computer and I pulled up every single patient portal I knew I had access to, which included my local PCP, my local nephrologist, and my Emory patient portal. And I pulled up all of my labs from all 3 locations, and I printed them all out. And when I printed them all out, I laid them out on a table, and I started looking at it, and I could see right in front of me, I had gone from a GFR of 70 to a GFR of 40 in just a few months.
Wow.
So I had a 30-point drop in my GFR during this time of these episodes of bleeding. And I knew something wasn't right with that. And I knew that I shouldn't have declined like that, because that's not what everyone has always told me about the disease. It's not how it works. So I kind of laid all of that out. And when I really felt like I had the evidence that I needed, I decided to go to a local ER and see if I couldn't get someone just to hear me one last time before I really gave up on what to even do. And when I went to the local ER, I was very fortunate to have a doctor that immediately heard me. He saw me, and he knew that I was at the very end of what was going on. And they did scans, they did labs, and he came back into the room. And when he came back into the room, he had told me that my GFR at that time was at 28. And he asked me if I had been preparing for dialysis or for a transplant. And up until then, I had no clue that was coming. Nobody had told me, hey, you might be needing to get ready for this. So I explained my entire situation to him, and he told me in that moment, you need to go back to Emory. He said, whatever you do when you leave here today, you need to go to Emory. And at the time, I was still on the fence with returning to Emory. It was just such a back and forth trip of going to Atlanta and back. And I was really wanting to be able to stay established locally, but I knew that I wasn't being heard. So I ended up reaching out to my nephrologist at Emory that I had seen throughout the studies. And I emailed him about, it was probably at like midnight. I had emailed him, and by 5 a.m. he had responded to me asking if he could call me and what my current phone number was. I gave that to him, and at 8 a.m. he called me, and he said that he needed me to come in as soon as I could. And he didn't even schedule me. He just fit me into his schedule. And when I got there, that's when I found out that I explained everything that had been going on to him. And that's when he told me that I was one of 5 of his patients that had ever done this. And between Emory and Mayo, I was one of 30 patients. And we all were of similar age. We were females. We were all of similar even build. And they didn't know the exact cause behind it. And it wasn't just necessarily that I had PKD1 of that gene, but they didn't know if it was a vascular issue or even some sort of allergy to a medication that we had taken that had caused a more rapid decline. But the only thing that would help it when we would have these frequent episodes of the blood in our urine and the pain was to end up with a transplant or dialysis, because once it started, it didn't stop. So while I was there that day, he pulled out a transplant referral form, which was literally one sheet of paper. That's it, just a one-sided sheet of paper, and wrote a referral for me to be seen in the transplant center at Emory. And that was in in December of 2019. And by the beginning of January of 2020, I was established as a possible transplant candidate for a preemptive kidney transplant at Emory. I went through the entire process, and I was actually denied at the time due to preserved kidney function, because per UNOS, to be able to be listed for a preemptive kidney transplant, you have to have a GFR of 20. And mine at the time was 28. So they wanted me to decline slightly more before I went forward with being listed, which there are 93,000 people in the United States right now that need a kidney transplant. So their reasoning behind the decisions that they makes a lot of sense. Doesn't feel like it at the time when you're the one that's declined, but when you look at the big picture, it does make a lot of sense. And this was March of 2020 that I received my letter that said I had been declined. And then COVID hit and everything got shut down. And for about a year, I stabilized in my kidney function. And from March of 2020 until I believe it was about January of 2021, my GFR didn't budge. I stopped experiencing the episodes of bleeding and the flank pain. So I was incredibly fortunate that I gained a full year where my disease went right back on the back burner, and it was not the everyday thought in the back of my head. And then from about January 2021 until now, I have slowly started to progress again in my disease. There'll be moments where I'll have kind of extended periods that I don't have a decline. And then there'll be moments where I have a more rapid decline. And what I mean by that is in December, I think it was December 29th of 2021, my GFR was at 20. And by March 7th of this year, so just a few months later, I was at a GFR of 16. So it's very hit or miss right now where my function is at. And so I returned back to Emory for another evaluation to attempt to get a preemptive kidney transplant. And as of right now, my GFR is 16. And once I'm at a GFR of 8, Emory wants me to start the process to prepare for dialysis, which my nephrologist at Emory is hoping to avoid at all cost. It is something that would sustain. I would be able to live with dialysis, but it's not the best options in the long run. And there's a lot of complications that come with dialysis that if I could avoid those by just skipping it and going straight to a transplant, I would have better outcomes, including with the transplant itself, if I had received the transplant prior to needing dialysis.
What type of dialysis are they talking about? Like hemodialysis?
I would attempt to opt for peritoneal dialysis. Okay. That way I could still work full time and still have somewhat of a normal life, because with hemodialysis, your life is kind of tied to dialysis. Whereas with the peritoneal, I could do it at home while I'm sleeping. And I am the person that carries our insurance for our family. So I need to work and I need to have a job. So after speaking with my nephrologist, he felt like because I'm overall healthy, that would be one that I could opt for.
Did they educate you a lot on peritoneal dialysis, what that all includes?
They have discussed it with me slightly. My nephrologist is incredibly hopeful that I won't have to do that. So I believe that he has tried to steer me more so towards we're looking at a transplant, but he has given me kind of the basics of what to expect.
Okay. And
In regards to transplant, so just kidney transplant, are we looking at deceased donor or living donor options?
So if I'm listed through Emory, I can receive a deceased donor kidney. The problem is people with my blood type, which I have type O, are sitting on the list for 5 to 10 years before they're able to receive a kidney transplant. And unfortunately, I don't have 5 to 10 years before I'll have to start dialysis. With what they're looking at Emory, I maybe have a year before I'll have to start dialysis, and I'll have to start preparing for it sooner than that, because you can't just start dialysis. They have to do surgeries in preparation, especially for peritoneal, because they put a tube in your stomach and you have to heal from that surgery before they start dialysis that way. If I am able to receive a living donor, I have a chance of receiving a kidney as soon as I find someone that matches, and as soon as we could get that scheduled.
Okay. To find a living donor, does it have to be someone you personally know or that you're personally related to?
No, they do tell you to look at your family first. I was adopted at birth, and I do know who my biological mother is. But since I was adopted, extended family is very limited. So I have to look outside of people that I am biologically related to. So it could be anyone. It could be any stranger that's over 18 years old. They could possibly be a donor.
How does one become a donor? If somebody said, you know what, this story is striking a chord with me, I would like to find out if I could even be a candidate to be a donor for Jamie. How could they do that?
So since I am in the process of being listed through Emory, they would go to Emory's website, and it is at www.emorylivingdonor.org, and they could register on that website. They would need my name, which is Jamie Sunderland, my date of birth, which is 6/24/86, and it will somewhat screen them from there. And I have had a few people that have already attempted to register, and it already kicked them out of the system and told them that they would not be a viable match at this time. So from my understanding, the screening process through that is pretty thorough, just from even the website.
Did they tell you if someone were to qualify to be a donor, what that entails as a donor?
Once someone has registered, they will send them to have labs, and they'll do like a 24-hour urine collection to see if there's protein in their urine. And I'm sure there's other things that they test for in the urine as well. And then once they do that, they will bring them in, do some further testing on those potential donors. I will actually be brought back in to check. They test for our blood type matching, and then as well as our tissue type has to match. And then if I'm given the green light and so is my potential donor, then from that point, they would schedule the surgeries for both of us. And for the donor themselves, that is a surgery that's typically done laparoscopically. And they are told that they can return to work as soon as 2 weeks after the surgery, depending, of course, on what type of work that they do. My health insurance would pay for everything that they would go through. That would pay for the screening for the transplant, the evaluation, that would pay for the surgery, and then post care.
Do you know how long the process would be for the testing process?
So that is not really something that they have told me. They had said that they would, the more people that the sooner that I had people register on the website, that would kind of bump me up on priority to getting the green light from the transplant team to proceed forward. And then once they have people that they're testing, they will do further testing on me, because Emory has recently changed the way that they're doing kidney transplant evaluations. Originally, when you first went in, you would get the full run of tests at that time, which is like an EKG, an echo, You have to have an MRI done of your abdomen. You have to have an MRI done and an MRA of your brain because PKD does cause brain aneurysms. You have to have, let's see, I don't know if I said it, you'd have to get an echo done. Of course, you have multiple labs that have to be done. And I think that's the main test that you have to do. But now, the way that Emory does it, they start with your labs, they do an EKG, and they do your chest x-ray. And then if you are approved to be listed, then you're brought back in, and that's when they do your echo, and they do the a CT scan or an MRI, and then the MRI and the MRA of your head.
Okay. Again, you're 35 and you're a mom. And you're active. I mean, you're, like you said, you're working full time. You're the one who's carrying the insurance for your family. I don't know. You don't have to say where you work, but do you want to say what you do for a profession?
Yes, I'm an educator at a small private school here in Chattanooga, and I am in charge of our RTI program, which is response to intervention. And I work with some of our students at the school that are still need a little extra boost in their reading and kind of help them with that.
I am trying so hard not to cry, Jamie. I mean, I saw your story, and I know you were a little bit reluctant to post it on social media, and some of your colleagues and your friends encouraged you to do that. And I don't believe you and I were friends on Facebook at the time, but I saw some of the shared posts. I saw it at least 2 times it was shared. And I was just sitting and I had absolutely no idea. And I'm sure that's possibly why you had some hesitancy with, your first ER visit. Looking at you, nobody would ever think there's anything wrong with you health-wise. You're young and you appear on the outside to be very healthy. But to read that story, it's just, it's heartbreaking, really, to think that it progressed so quickly with you. It is a little bit humorous to find out how you were diagnosed with wanting to skip school.
It's a good thing you did want to skip school, though. I mean, looking back.
Yeah. See? So it was a good lie.
Right. But kids don't skip school.
No, don't do it.
Jessica, do you have
I do have a question about when can your daughter start getting tests or like seeing if she has potentially could carry it?
So when she was 2 years old, I actually took her and had her tested. They did an ultrasound, and she did not show any signs of the disease at the time. And I spoke with my nephrologist at Emory, which his name is Dr. Abari, and he had told me that at the time he had said not to push getting her diagnosed at this time because it would put a red mark on her medical history for the rest of her life. And especially when you look at health insurance and life insurance policies and things like that, not to go ahead and mark her with this red X as having a chronic inherited disease. So he's told me what to watch for with her, and that's what I've done. And thankfully, Lucy has not shown any signs of the disease. And I pray that it stays that way because it is a 50-50 chance of passing the disease to her. But I am praying that never happens. But if she were to start to show any symptoms, then I will proceed forward with having her tested.
Looking back, do you think that you actually did have any symptoms before you went in to get tested?
I think that I did because I remember having a lot of UTIs. And what's really kind of interesting, when I was 9 years old, I ended up getting sick and I went to the hospital, and I ended up being admitted into the hospital for 2 weeks because I had osteomyelitis. And I do not know where I got it from. I cannot remember anything about that, like how that originated. But I had to go through all sorts of tests at that time. And they never saw my disease. They never picked up on it whatsoever. And that was at 9. And so between 9 and 16, I don't know what happened, but nobody ever saw anything. And then I was fine, except for, like I said, I remember having pretty frequent UTIs growing up. And then at 16, I was diagnosed.
Okay. When did you find out you were adopted?
I found out I was adopted at 11.
Okay.
And my mom I had noticed there were no photos of my mom when she was pregnant. And I asked why there were no photos. And that kind of opened up that conversation.
Inquisitive little girl.
I was very much.
And then, so at the time when you came out and you told your aunt that, that they mentioned something about kidney, did she have any idea what your biological family history was at that time? Or is that something you found out later?
So I was adopted into my maternal biological family. So biologically, my mom that raised me would have been my great aunt had she not chose to love me and raise me as her child. And I was adopted by her at birth. So my aunt biologically would have been my grandmother.
Okay.
That I said this to. And actually, when I got diagnosed, my mom had come back from taking care of my grandmother, which was my mom that raised me, her mom. And she met with my pediatrician. They told her everything that was going on. And my pediatrician did explain to her that this was a genetic disease that I had to have inherited from a birth parent. And we did not know at the time if it was from my biological father or my biological mother. And my mom contacted my biological mother and told her she needed to get herself tested and her other children tested. And that's how my birth mother found out that she had PKD.
Wow. Okay. And you mentioned one of your other biological siblings.
Yes. She has 2 biological sons, and it is her youngest son that has PKD. I do not know about his stage, like what stage of PKD or chronic kidney disease that he's even in. And her other son, I don't believe he has the disease at all.
Okay. You said about a year from now that you would need to begin dialysis if you can't get transplanted.
Yes.
Okay.
My nephrologist said that we will try to hold out as long as possible. And he has had patients that have had a GFR lower than 8 and that have been able to hold out and wait. And typically the younger you are, the better off that you are. You can wait a little bit longer. Right. Whereas if I was older, I would have to start way before I hit a GFR of 8. And he said that if I am able to do peritoneal, the prep for peritoneal dialysis is about 2 months prior to starting dialysis, whereas hemodialysis, it's a much longer prep. But he didn't really go into details about how much longer, because like I said, he really is trying to push for the preemptive transplant.
Right. Are you only seeing your Emory nephrologist now? Did you forego the local? Okay.
Yes.
I don't blame you.
I'm only with him. Yeah. And, one thing that I do want to make sure that I say is that I think when you have a very specific disease in particular, like you're not my kidney failure is not due to something like diabetes or just high blood pressure, but it's a very specific inherited disease. I think that it is so crucial to find people that know that disease. And I just so happened to be fortunate enough to have a pediatrician that, yes, she was a pediatrician, but she was also an adult nephrologist. And she knew to get me to Emory, and she knew who had a whole center dedicated to my disease. Whereas there's a lot of people out there that don't have that opportunity. And I don't ever want to I want people to know that I realize how fortunate that I am to have that, because I can only imagine if I wouldn't have had people that know this disease as well as they do, that have dedicated their whole lives to renal cystic diseases. And as for what happened locally with the nephrologist, I think that they truly did believe that this was the typical progression of PKD. And I don't believe it was done with malice. I do think that when you look at me, you would have never known that I had these problems. And typically, unless you see a scan of my abdomen, you wouldn't believe that if I told you that my left kidney is 12 inches in length. You would never know that to look at me from the exterior. And I think that it's very hard to take someone like me seriously because I don't appear to be sick. And I understand that. I mean, I would probably be guilty of the same thing if I worked in the medical field, honestly. And I think that I don't believe that they didn't want to hear me out of malice. I think that they just didn't understand that there was something more to this. Because if you look at the statistics, I'm one of 5 patients at Emory, 1 of 5. And there's so many of us at Emory that have PKD. And then between Emory and Mayo Clinic, I'm 1 of 30 that my doctor has seen that has done this. So I do feel like even if it wasn't because they didn't care, it was that they just didn't know. And one other thing I do want to say is that I know what I'm asking for is not a small request. And sorry, I was raised to be incredibly independent, and I always have been. And now I have to have someone, and I have to have someone that is willing to give of themselves, something that I'll never be able to pay back. And I know what I'm asking for. And I want anyone that is hearing me to know that I know this isn't a small decision and that I don't think less of them for hesitancy or being scared, because I don't know what I would do if I was being asked to donate an organ if I didn't have someone directly impacted by it myself. And I know what I'm asking for is major. And I want people to know that I think anyone that is in my position right now realizes that, and how incredibly appreciative that I am that anyone is just willing to listen to my story and to hear me. And if anything, if they will just register to become a donor after they are no longer here, just so that somebody has a chance at life after that person has passed. And that doesn't mean they have to register to donate to me right now, but there are so many people out there that need an organ. And just like I had said before, just for a kidney, there's 93,000 of us that need a kidney in the United States. And there's not that many organs out there. So if anybody is willing to at least just register to become an organ donor after they have passed, then I feel like I have done something with my message to people.
I love that.
I appreciate you sharing your story with us, and we will do our best to make sure that we can touch as many people and get your story out and get your info out. And we'll put, I wrote the website and your birthday and your name. We'll put that all down in the podcast notes. So if anyone wants to go and look into it, they have it right there at their fingertips.
Thank you. And I did create a Facebook page because I was told by some people that had received transplants or their family had received transplant to do so. And I was going to wait to actually publish it. Like I just have it on there when you guys release this. But the name of it is All My Kidneys, like after all my children, the soap opera. And I've got like a whole list of names that are all around soap opera names. But I'll be using that to kind of post updates of what's going on and have links to everything on that Facebook page.
Okay.
But you guys, I want you guys to know how much I appreciate that you guys wanted to share my story. And when I was told at work by Miss Joanne that you guys wanted to share it, I didn't even really know how to respond to Joanne. And I don't like to cry in front of people at all. And so I just tried to sit there, and I kind of froze, and I started to cry a little, and then I pulled it back together. But I didn't even know what to say because it just meant so much to me. So thank you guys for wanting to hear me and help me get this out. You have no clue what it means to me.
Our pleasure.
Thank you so much for sharing with us, Jamie. It's Jessica cried.
I also don't like crying in front of people, so I want to go off screen.
But I thought,
she has cried in over half our episodes. I really hate crying in front of people. I think I've cried in maybe two. This might be the second or third that I have. It's, but yes, this is a very emotional and emotional, I think, also because something can be done. You know, it's not like a dead end, like, oh, that was a really sad story to hear, but it's this can actually go somewhere. And I want it to, and I want to do what we can to make it happen.
oh, thank you. You guys I just don't even know. Yeah, I mean, I just can't imagine what you guys are doing, and it just means a lot to me.
Yeah.
I cannot thank you both enough.
Our pleasure.
Okay.
Well, thank you again for coming and talking to us. It was so nice meeting you.
Enjoy the rest of your day, Jamie.
It's nice to meet you.
Bye.
Okay.
Bye.
Hi, everybody.
Hi, I'm Annette Needham. I am the transplant quality manager at UCS.
I'll go next. I'm Stephanie Baroni. I'm a living donor coordinator.
I'm Kimber Simmons, and I am a living donor transplant coordinator at UCS.
And I am Janie Young. I am an administrative assistant 3 at UCS in the Kidney Transplant Center.
Thank all of you so much for joining us. We're excited to have a transplant special for April. I am just meeting all the rest of you, but I know Nettie forever. And what better people to get on to give us sort of the experts information on donation, and specifically living donor donation, but really all organ donation. So I'm not sure who wants to go first, but if you want to just kind of start talking about things, some topics that came up with Jamie were UNOS, PKD, dialysis. Oh, what else?
Well, something like a non-transplant medical person, like my fear being if I was to be a living donor would be like, how can I function with, less of, one kidney, or like at what impact that would have on me. So that'd be a good thing to cover too.
Yeah.
So take it away.
Not to be totally selfish about giving an organ away, but
you can live the thing about becoming a donor, and Janie can speak to this, is you join a very exclusive club where we think you are healthy enough to be able to live a long, healthy life with only one kidney, because donating a kidney is voluntary. Most people are born with 2, and to donate 1, we're saying, yep, we trust you are going to be the healthiest you can be for the rest of your life. And most people can. Most donors live a very long life with only 1 kidney. I mean, the statistics prove how long they live with 1 kidney. So,
and I always used to tell my patients that, you have 2, but they work together. They don't work alone necessarily. So when you're going to get taken out with some disease, it takes both of them. They go down at the same time, unless it's an accident where one gets injured. That's typically how they go out. So really, it doesn't make a difference if you have 1 or 2. That's what I used to say too. And remember, Kimber, what did we tell people? It's the best workup they'll ever get in their entire life to do a donor evaluation. And I'm sure Janie can speak to that.
I've done it twice too. They've done it twice on me. Yeah. And I'm healthy.
What does the workup consist of? Just like checking all your labs and making sure everything's okay?
So when we're evaluating somebody for the first time, it's kind of like preliminary, check your chemistry, your kidney function, your urine, see if your kidneys are dropping any protein, and a blood type, and then a regular CBC if there's anything abnormal with your red blood cells or your blood volume. We do, part of the chemistry has to do with your fasting lipids. So these are fasting labs that we want to look at what your fasting blood sugar would be. Are you pre-diabetic? We're looking for that. And your lipids, if they're too high, is that indicative of your diet? Can it be, problems down the road if you're not going to change your diet? And we also do hemoglobin A1C to see if there's prediabetes or diabetes, and an insulin check. kind of helps us look at how well your body's using insulin that your pancreas is throwing out. It can also give us another story of, is there something going on before we even put somebody through a thorough evaluation.
Wow.
Is there an age group that can donate?
Transplants all over kind of make that decision, like how young should we go? We were just on, we get emails from a group from the Kidney Parent Exchange out of UNOS, and some centers won't even accept anybody unless they're 21 or older. And then I think most transplant centers are 25 years or older, huh, Steph?
Yeah, for the non-directed donor. We call them non-directed donors for 25 and older.
Okay, and can you explain the paired exchange thing?
Oh, paired exchange is amazing. That's a swap program when you are not compatible with your recipient, and either your blood types don't match, or maybe the recipient has antibodies against you. We offer the paired exchange, and paired exchange hasn't always been around. It's something that came into play years ago, but hasn't always been that way. So now you can swap. You still donate your kidney, but it goes to a stranger, and your loved one or your recipient gets a kidney from a stranger. So you swap kidneys. So it's pretty cool what you can do with it. And some people just voluntarily want to go into that swap program. If they're a blood type O, they want to help more pairs. And Kimber and I have been really lucky. The past 2 swaps that we've done, which have been what we call 3-way swaps and 4-way swaps, have been started with someone who wants to help other people. They had a recipient, they were compatible, but they wanted to help other people get kidneys. So been really lucky to have, we just completed a 4-way swap where we had 4 donors and 4 recipients. So 4 recipients got living kidney donors.
Is that
so
nationwide?
Amazing.
Is that nationwide
This was
or
not
global?
This was within our own local center.
Oh,
Kimber
wow.
and I did.
Oh,
we
okay.
had a matching computer program that we used to match pairs. And that was within our programs.
Okay.
Yeah, and we just signed on with a national company, actually, NKR they're called, and Ingrid will probably remember the NKR days at Florida Hospital. But yeah, we're the 100th center actually to sign on with them. They did a little press release last week, and so we're hopefully going to be doing more, and they will be national then.
What difference will that make for you
your
guys?
kidneys go everywhere. Kidneys will go from Sacramento to New York, and from New York back to Sacramento. So it's a bigger pool of people for recipients. So maybe they can get a better match, or that they don't have to wait as long for their match. So it's a big pool of donors and recipients that will match them.
Do you have any idea what the average wait time is for somebody with blood type O for kidney?
That's a good question. Well, it depends on the area they live in. So for example, even just here in California, an O type, because we're kind of smaller and the way the allocation was, our wait list was kind of, we could get through them really fast. Plus it depends on the appetite for risk for that transplant center. So some take more risky kidneys than others from the deceased donor list. And our surgeon did kidney repair. So he would take a potentially damaged kidney and repair it before he put it in. And so we were known to take more kidneys. And so we got through our list faster. So for us, like an O would wait, 3-4 years. In the Bay Area, they would wait like 9 years, and that's just 100 miles away. So, it kind of depends, but California is one of the worst for wait times. I want to say in Florida when I was there, it's a few years ago now, but I want to say there it was about 3-4 years standard.
UNOS will give us our average wait times and will give us our years based on blood type, but that's an average over the nation.
Yeah.
Every year they let us know what the wait time is. And that's why we tell people so much, please, spread the word that you need a kidney, which is hard for people to do. It's hard to get that word out. It's easy maybe to ask someone to borrow $10 for lunch, but let's ask someone for a kidney. It's much, much harder to do. But your wait time, your statistics prove that your kidney is going to last much longer. So
It's funny because our executive director is also a kidney donor, and she was at Mayo, and she said the lady that she donated to is called Risa Simon. She wrote a great book, and she has a website, and we actually use her program now. excuse me, called Donor Seekers. But she told Melissa, okay, they were standing in line somewhere. She said, go up to that guy over there and ask him for $100. And she goes, I'm not going to do that. Why would I do that? And she said, that's 10 times better than asking someone for a kidney. She's like, that's just a minute example of how it feels to need something to ask somebody else. And so I always remember that story, because it's true, right? And so it's much easier for someone to ask for somebody else, right? So I'd be quite happy to say, hey, my friend Ingrid, she's really nice, but she needs a kidney, and, kind of do it that way rather than me say, I need something, right? So, there's donor champion programs, there's donor seeker, there's all these different things, but it's geared on that person having a cheerleader, if you will, or like someone that's willing to speak out to people, spread their word for them. And so we just started doing that, right, Kimber, with our social worker.
So how do you guys go about, is it just a website that you have people kind of plug into to help direct them, or how do you do that?
So we do have a website that is an application that if somebody wants to be a donor, they go onto it. And this website asks a lot of health questions to help us get a better idea if it's an automatic, you've got some health issues that are just too risky, or there's some health issues that we may be able to work with, or that they don't have any. So it gives us a lot more detail up front versus a nurse having to do this all over the phone. And then once the application comes in, we have what we call an independent living donor advocate. So we have them as the first step in reaching out to our living donors to start explaining what the whole process is and gather information more about them, about why do they want to do this? Who are they doing it for? Are they doing it just because they want to do it, or they feel, are there other reasons why they're stepping forward? So they do an assessment to see where that person's coming from, what they understand. Do they really know what they're getting into? And then they start giving them the education about this journey that is pretty involved. And then they give the referral back to us, and that's when we start the preliminary blood and urine testing. And if they pass that, and Steph and I have a conversation with them about their blood work and then what the next step is, which is
the presidential workup.
Now, if say there's somebody in Massachusetts that decides that, they want to be an organ donor, but they don't have anyone, how do they find a transplant center to begin that process?
There's actually several ways. They can just go on UNOS. So UNOS is the United Network of Organ Sharing, as you know, Ingrid, and they can just go on there and they can click on members and look for transplant centers. So they can do a search of their state, of their city. You can look at OPOs, either one. But then these transplant swaps, like the NKR, you can go and register to want to be a donor on there, and they will help you find a center close to you and put you in a swap even. So they kind of facilitate more of a chain. So there's a couple of different ways.
How are the people that get transplants doing? Are the majority of them faring well, I guess?
Yeah, we follow them. I mean, we do, as Annette was kind of talking about with UNOS, we report our 1 year survivals on patients and their 1 year kidney function survival. So because living donors want to know, if I'm going to do this, is it going to be successful? So we report that to living donors, and we have to give data twice a year to UNOS, the Scientific Registry of Transplant Recipients, another website that is open to the public, to look at every transplant center, what their statistics are.
So they give you national average, and then they give you your center. And there's kind of one with bar charts. When you first go to that transplant center, there's like little bar charts so the patients can understand rather than like look at all these figures. But then if they want to have a deeper dive and they're like, scientific-y people, or they have a bunch of questions, then they can drill down further and look like, well, how many did they do? How many females? How many O's? How many B's? And you can really like get a bunch of data on that site. And like Kimber said, being the regulatory person, we do provide that to patients twice a year on evaluation and then twice a year.
Post-transplant patients, they do get put on a lot of immunosuppression. So transplant it's not a cure, but it is a better quality of life for our recipients. But they do get put on a lot of medications that can cause problems for them. We suppress their immune system. So that means that they're susceptible to a lot of other things. So there's a lot of things that they do deal with, and transplant is one part of their journey. Their next part of their journey, or the next part of their chapter in their book, is living with a transplant and how well they do with it. And there's a lot of different factors that go into
that. Nettie, you mentioned living donor, deceased donor. Somebody it's pretty self-explanatory, but could somebody just kind of talk through perhaps like what organs can be a living donation? And I know each center is different also as far as how far they can go with those.
Yeah. So for living donor, you can donate a lung, you can donate part of your liver, you can donate a kidney, cannot donate your heart, at least not in the United States, because you need it. You need the whole thing.
Other countries, they, for the right amount of money, someone can
I
buy
gotcha.
anything.
Gotcha.
It's illegal in the United States.
That seems good. That seems like a good thing.
Yeah. Yeah. Most people don't know that it's an actual federal law that you cannot accept money or anything valuable in exchange for an organ. So
really,
and people always say, well, how do you know that they're exchanging? I think over the years, Kimber and I you get a feel for people that are being coerced or pushed or offered something. It's extraordinarily hard to prove. So programs can really just say, we just suspect coercion and not accept a donor. So it really is against the law. I know Grey's Anatomy thinks that anyone can do it, but yeah, we're not portrayed that way very well on the Grey's Anatomy and all those medical shows.
The hot upcoming thing is VCA. So it's vascular composite allograft. And that is basically anything that's not an organ. So it's like hand, face, uterus. There's a lot of those transplants. Obviously, they're the biggest centers that have the resources to do them because they're very labor intensive. But those are really pretty cool. There was a lady who had a baby last year with a transplanted uterus.
Oh, wow.
So it was pretty neat. Yeah.
That's amazing.
So we talked about UNOS. Could somebody just sort of go over, there's 3 other topics that were discussed with Jamie that we probably need to explain more, but PKD, there's peritoneal dialysis versus hemodialysis, and what GFR means in terms of needing transplant or dialysis. Nettie, you used to work nephrology.
Yeah, I mean, we're all kidney girls, right? But so, polycystic kidney disease is really kind of hereditary type thing. So that's why families can't often donate. But there are just a lot of cysts. Like you'd get, skin diseases with cysts on, you get kidneys with a bunch of cysts. And they can grow in size, they can bleed, they can pop. They can just cause so much pain for these poor patients. And typically when we do a kidney transplant, we don't actually remove the native kidneys unless there's cancer. But PKD is one of the diagnoses that we might remove the kidneys because there's no space in the rest of the abdomen to put any other new kidney. So we actually do typically remove PKDs, or at least we keep an eye on them because they can cause problems. And they can get infections when those cysts rupture, and you can imagine. So that is PKD. I'll let Kimber or Steph do GFR.
I actually have a question as to what you just said. So in other transplants, do you leave the old kidney in there?
We do. Some people have
Oh.
four kidneys because the native kidneys are kind of in the back, right? Just above the waist. When we put a transplant in, we put it in the front, the iliac fossa, so kind of just by the hip bone. And the reason for that is A, because it's easy. It's right there. You don't have to cut through the back and the muscles and everything. And B, it's easily accessible to do like biopsies on in case they were getting rejection or something's going on. So I actually had a patient that had 4 kidneys because he had his 2 natives and he had 1 transplant and then he needed another one. So yeah, we just keep on putting them in if there's room.
Move over, kidney. Here comes the new one.
All right. Sorry. I'll let the rest of the questions be answered now. I forgot what they were already.
No problem.
GFR.
You want to go for that one, Steph?
No, Kimber, you go for it. I feel
So,
like I'm talking too much.
no, you're not. GFR. So that is, in a simplified explanation, the function of the kidney. And both of our kidneys work together to eliminate the byproducts and how well they filter out those byproducts. And over time, when the kidneys are scarred and not working for all the different many reasons that can cause kidney failure, you start losing that function, and then your kidneys aren't working for you. And so we are, I think when you've got really super healthy kidneys, we're around an 80%, 90% function rate. But then as we get older or we start having kidney problems or kidney diseases, then that function drops and it can get down low. Anything below 20%, you're going to start needing to think about a transplant. And anytime someone starts getting below 16%, then they're going to have to start thinking about hemodialysis or peritoneal dialysis. And when you start reaching 10%, then
You're kind of gray and you don't feel good and you're nauseous.
And you're itching and you're
yeah,
fatigued, very fatigued.
And you have anemia.
Right. And then, so what's the difference between peritoneal dialysis and hemodialysis?
you get to explain that one, Steph.
All right. Peritoneal dialysis is dialysis that essentially you can do at home. It's through a tube in your abdomen, and you exchange your fluids every night. You hook up to it in your room, probably your bedroom. It's a sterile procedure. You exchange all those fluids out and put them back in. Hemodialysis is at an actual dialysis center, and that's where you have a graft in either one of your arms, where they hook you up usually every other day, go to it 3 or 4 days. And that's in the center where you're hooked up to a machine that actually does the filtration rate for you as well. Pumps, filters out, puts it back in. Peritoneal dialysis, use a machine as well, but you're at home doing it and you are the one doing it. At a dialysis center, you have a professional, so to speak, to do it for you.
Hey, but don't forget about home chemo. Now they're pushing home hemodialysis because technically hemodialysis is somewhat superior to peritoneal dialysis as far as clearance, like clearing the urea and everything from your blood. However, if you think your kidney works 24/7, even hemodialysis, you're doing it 4 hours, 3 times a week. It's really not enough. And patients get these fluid shifts in between. They get pain and cramps and all kind of issues. So they came up with, well, some patients are really smart enough. If they can do peritoneal dialysis at home, surely they can do hemodialysis at home. And so they're actually doing a lot of that now. And you'd go on it for longer because you're home and you're comfortable and, you can do 8 hours or 10 hours or whatever. And you can do it every night, potentially. So that is something that's becoming a little more common. But you have to be pretty smart to do that, because imagine you don't hook up right and you'll bleed to death because you don't hook up right. So it's a little scary to me. I did dialysis a long time ago. And so I don't know, I see these like things that come and I'm like, oh, I don't know about that.
Yeah.
So is the main thing like having a graft? Is that what's like the big difference between the two?
Or a fistula, which is similar.
Fistula.
Yeah,
Okay.
fistula is like your own hardware, if you will. Like they change your vessels around so that they create this loop that you can hook in, and you have an in and out. A graft is a device, like a kind of like little plastic tubes that they put in instead. So that's a graft. And then there's also temporary kinds where they put the lines in your neck, but those can't stay there very long. Yeah.
Okay.
No, you're like, don't touch me.
I don't know if I could handle that.
That's why living donor's best. Like bypass that whole thing.
So here's a question. What happens if somebody were to get an organ, and not just kidney, but any organ, and it fails immediately? Then are they allowed to get another transplant, or what can happen?
Yes. Depending on the reason for the failure, we call that primary non-function. So if the kidney does not function, like the GFR does not fall below 20 in 3 months, 90 days, you can declare it primary non-function. You can put them back on the list. You petition UNOS, you send a form in and you say this, hey, this never worked. Look at their labs. It's awful. And they give them all their time back too. So they don't start again from scratch. Now, of course, they have to, depending on the reason, we've had some patients that like clotted the kidney off. And so, you've got to do a whole workup on them, make sure they're not going to do it again because they're precious, right? And so we have to sometimes check the recipient out again a little bit more. But sometimes it maybe just wasn't a good kidney, or we didn't realize it at the time, or, they get super low blood pressures in the OR, or something happens to them that we didn't expect, that causes the demise of the kidney.
And what about long term? Is it, somebody, say Jamie gets her transplant at the age of 35. Is she done for the rest of her life? Or what happens if she has issues with her new kidney later down the road?
If she has problems down the road, it depends on how bad those problems are. If she may need another transplant in her lifetime, it's hard to determine especially with PKD. Chronic kidney disease can take a lifetime to develop. PKD is a little bit different. So there is a chance she might need one again when she's 60, 65, because the medications we put you on, the tacrolimus and the mycophenolate, those are anti-rejection medications, are also very hard on your kidneys. So it's a fine balance to make sure that we have enough that suppresses your immune system, so your immune system doesn't recognize that the transplant is foreign and try to essentially kill it off, versus a balance to make sure that the medication's enough to help that and not kill your kidneys at the same time, because it can be, those medications are very harsh and can be very hard on the kidneys. So there is a chance. It's hard to determine. And I tell everyone and my donors that transplant's not a cure. Your kidney could fail and your recipient could need another kidney in their lifetime. But the chances of getting a living kidney to last longer is much better versus a deceased kidney.
What do you guys see as like the primary cause of kidney failure or kidney problems? Like, do you see like a theme or like a general thing?
Oh, yeah.
In the general population?
Diabetes and high blood pressure.
Oh, okay.
Diabetes is the number one reason for needing a kidney in the United States today. High blood pressure is pretty close second. So,
but usually
crazy.
Both. Yeah.
I would never think that high blood pressure would affect my kidney. I had no idea.
And so we tell our donors that people who have high blood pressure and they're supposed to take their medications, I wish physicians were more clear to them that it's not just about, keeping that blood pressure down and you think it's not a problem because you don't have a headache. It's really about keeping the perfusion to the kidneys. The high blood pressure squeezes the life out of those kidneys. And it's a silent killer. So people don't know what's happening. My mother's one of those people who wouldn't take her blood pressure pills. I don't have headaches. I'm fine. My blood pressure is 150 over 90. What? And she said, well, the doctor never told me that I had to worry about my kidneys. That's the part I think is missing when doctors talk about people and what high blood pressure does to their body and why you're taking the pill.
I'd like to discuss now some myths about transplants. Did you have a different question, Jessica?
I am dying to hear Janie's story.
I know I want to end.
Okay. All right. As long as we're getting there.
We are. But typical myths, like if I put down I'm an organ donor, they're not going to try to save my life. They're going to let me go instead so they can, I know this is a bad word, harvest.
So my husband thinks.
No, that is so no. I didn't work in the ED very much, but they're not even thinking about that. Like, they're all heroes down there. They just want to save a life. The last thing they're going to do is try and divert a life. Not going to happen.
Mm-hmm. And I was an ICU nurse for a long time, and the same thing. Our whole focus is saving someone's life. Like you're doing everything you can, and you'd feel like if you couldn't save them, that you were such a failure. So yeah, that is like the farthest thing.
Are there any other myths that you guys typically hear about transplant that people they're like, I was reluctant to be a donor because I thought this?
I don't know do you remember the story where they used to always say that people would wake up in the bathtub after
make
partying,
you a donor
and missing a kidney?
Mm-hmm.
And they were like, and you survived? It just doesn't work that way. Just take a kidney out and give it away.
And you don't bleed to death, right, in your bathtub. Yeah, there used to be a lot of myths. There used to be some that said like religions don't agree with it and different things like that. And I don't think it's a matter that they don't agree with it. I think it's just that they have different guidelines for when somebody, is dying, what they do with the body and when, and, those kind of things. So I think that might be a little bit of a myth too, or my religion doesn't support it kind of thing. But I think most do. I don't know if you guys have had any experiences, Kimber or Steph, with that, but
I have. I've had people. I've had a young lady that was in. Can't remember what she was right now, but her elders would not let her donate. She went through the whole process, and they would not let her donate. She was in her 30s. I can't remember what religion. And then I have another girl that was very hard, and she and I had long talks about it, and she still has not made up her mind because her parent. The biggest thing I run into is parents don't want their kids to donate. So it's not really a myth, but it's just difficult, for parents to see their children wanting to donate a kidney.
And then I was just in Egypt, and my daughter got married, and her father-in-law is a nephrologist in Cairo. And he said, all the transplants are living donor. They have no deceased donor transplants there.
wow.
Isn't
They
that
have
weird?
that many people who want to donate, or they just don't do
Like
deceased.
they have no deceased donor. I don't know if it's the Muslim culture that, I really don't know why, but that really surprised me.
Well, I need to look into this now. I'm curious.
Yeah.
Yeah, I wonder because, you'd think if they just didn't think it was the right thing to do, I wonder if you'd get more living donors just because that's the only option.
So I just thought of this question. On average, do you have how long a living donor kidney typically lasts versus a deceased donor?
Last quotes I heard, the girls may know better than me, is about 17-ish for a living donor and about 9 to 11 for a deceased donor. And the reason being, I used to tell patients it's kind of gross, but I used to say it's like the difference between fresh and frozen chicken, like the living donor is fresh, it's like right there. The deceased donor goes on ice, it's in your freezer, not quite.
I'm going to use that
you
one.
get the picture. You get the picture.
I'm never going to eat
It's like
chicken
the
again. Thank you,
simplified.
Nettie.
I miss working with you, Nettie.
Hey, you got to keep it simple.
Yeah, those are about the right averages that I've heard. I was teaching a class one time with patients that needed transplant, and I had a woman stand up to tell her story where she was getting her second transplant. She was 60 years old, and her first transplant was from her sister in their 20s. And now she was in her 60s. And that was a long one, but she was very proud of that. And it also really depends on how well the transplant recipient takes care of their body and, listens to what their doctors want them to do, taking their medications. It's not easy to take, 10 to 15 medications 3 or 4 times a day. And all those medications come with side effects that are not always fun as well. Mycophenolate causes diarrhea, and I've yet to see a recipient not have an issue with that. So it was a lot of side effects. So it can really depend on how well they do after transplant, how sick they were going into transplant, how healthy they were they active, were they, how was their functional, were they working out, or were they just not able to because they felt so poorly. So.
Janie, maybe you can answer this. Does a donor have to take, do you have to take any medications or supplements after you donate?
No, nothing.
Oh, wow.
Nothing.
Okay.
The only thing I cannot take now is Advil or aspirin, which I was never really taking anyway. So, and drink lots of water.
Oh, okay.
Yes. Water.
I think this is a good segue to let Janie kind of take it.
Please, I am so dying to hear your story.
How did you make the decision, Janie? How did it come up?
Well, my brother-in-law has kidney failure, and I wanted to donate to him, but he's on a Greek island and he couldn't come here. And in Greece, they have different rules, and he wasn't a candidate in Greece. So I thought I really wanted to donate. And same thing, I had a cousin that went into kidney failure from something he was exposed to in the Gulf War. And he was on a waiting list in England, and immediately he got transplanted. They have different allocation rules there. So I thought, well, I'll donate to somebody here then. And so I just decided that's something I would do, because I'd been working with these patients that are chronically ill and desperately waiting for a kidney, and some of them dying while they're waiting. And I thought, I'm so blessed that I'm healthy, really healthy. Why not share my spare, so to speak? So I did it.
Did you choose who you gave it to, or did you just go in and see who you were matched with?
Well, it was one of my patients. So
okay.
I knew that we were the same blood type, and I knew that we were the same age. So, and I picked her actually because we both had elderly dogs. And one day I was on the phone with her and I heard a dog in the background. So I always say to my patients, oh, you have your helper with you. What kind of dog do you have? And it turns out she had a German short-haired pointer that was 17 years old. It was her child, basically. And then one day she sent me a video of her dog in aquatherapy, in a harness to strengthen his muscles. And I thought, oh my goodness, she is taking such good care of that dog. She would take really good care of a kidney. And so that's why I chose her, because she took such good care of her dog.
How did that go about, you telling her that you were interested in donating to her?
Well, I was actually not going to tell her to begin with, but then I decided I would, because it was just, they said if it's confidential, then you have to recover in a different section of the hospital. And I thought, no, I'll just tell her then. I'll just tell her. So I told her one day on the phone. I said, are you sitting down? And then I told her.
How did she respond?
Oh, she was, no, you can't do that. I don't want you to be in pain. No, I don't want you to do that. She was in shock. She really was in shock. And we met actually for the first time on when she came in for her pre-op. We met And then we met again at before surgery when we were checking in, and I visited her after surgery. I went to her room, and then I haven't actually seen her. Haven't I've seen her. We've texted and we've been on the phone, but we haven't met since because of COVID.
Yeah.
So how long ago was this that you donated?
So she went home Thanksgiving Day 2020 with my left kidney.
I love the way you say it. Did she name it, Janie? Did she come up with a name?
Yes, the name of the kidney is Maddie.
Oh.
In memory, I have a very good friend in England whose daughter died waiting for a heart transplant. She was 19 and her name was Maddie. So I donated in the memory of Maddie.
Oh.
So that's why we called the kidney Maddie.
I love that.
What are the differences between England and the US? You said like the criteria was different. Is it easier here to get a transplant or is it easier in England?
I actually really don't know.
Oh, okay.
I think in my cousin's situation, I think because his kidney failure was directly related to his service to his country, I think they kind of bumped them up, I think.
Okay.
But I don't know that for a fact.
Okay.
I don't know that for a fact.
Gotcha.
But
Yeah, I don't know how their list works, but they do have different, like they have almost a presumed consent there where they don't really ask. If you sign your driver's license, like that's taken as a given kind of thing. For sure in France, they do that. I think also over there, because it's a National Health Service, you're not entitled particularly to anything. So, they have strict cutoffs. Like if, here we say don't smoke and things like that, but, we kind of don't really control it that much. But in England, they do. Like even vascular surgery, if you need your veins doing in your legs, if you're a smoker, they'll just tell you no. You don't get that. So I think it's kind of more strict. I think they don't take as many older patients that we do. I think there's things like that because the organ source is scarce, and so they really try and control it. Plus, they hold all the purse strings, and so they're controlling all of the money side of things too, because it's a pretty expensive operation.
Does the United States have anything like somebody would get bumped up for any reason other than lab values or health status?
Yeah, for kidneys, they really only get waiting time for the most part. If you're under 18, you get special points for pediatrics. If you're a prior living donor that ends up needing a kidney for some reason, you get extra points. And if you're a primary non-function, you kind of go back to where you were, so you get your extra time. But it's an algorithm basically based on time. They get a few extra points too if they have antibodies. So those are if they've had exposures to prior organs, pregnancies, or blood transfusions that mean they have antibodies circulating in their blood that can potentially react with a donor. Some people have really high levels. It's a percentage. So if they're at 97% or above, that kind of means that they might not be compatible with 97% of the population. So obviously they need to get exposed more, so they get more points. Sorry, it's complicated.
It is.
Yeah. There's controversy of once you're compatible with someone, like don't mess it up. So, I don't know if you remember that case I had in Florida, Ingrid, when I was doing living donor coordinator there. I was just devastated. For some reason, I think it was a husband and wife. They were compatible. We were going ahead. They did their pre-op. Everything was great. We did final cross match, incompatible. I was like, why? And I called them right up. Have you had blood transfusions? Have you done this? Have you done that? No. The only thing they had was a flu shot. I'm like, there's no way the flu shot gave them this. So, we debated back and forth. There's some very, very minute research that any stimulation of the immune system could potentially cause a reaction. But then the lab director was also like, well, they're husband and wife. They're kind of mixing fluids all the time. Maybe there was some recognition thing. I'm like, okay, I'm not going to go with that. So, that was unfortunate.
Mm-hmm.
Have you seen, that just made me think, have you guys seen anything, like has COVID had any kind of effect on someone being a match and then kind of similar situation going and then all of a sudden finding out that something's happened to where they're incompatible?
I had one recently where the antibodies flared up after they had COVID, and we rechecked in a couple of weeks. They were right on the cusp of being not compatible, but we rechecked and the antibody level came down, and so we were able to do the direct donation.
Yay.
I have had a lot of donors or recipients that get COVID, and I have two that
schedule.
Yeah, we got rescheduled, but that now I had two during 2020 and 2021 that have never been able to reschedule due to their illness. The recipient's illness, not the donor.
Because of like long-term.
Okay. Long-term issues on oxygen, all those long-term clots, things like that. Yeah.
Jamie, have you had to alter your lifestyle at all after donating?
No. I just no.
You're looking at a very healthy woman. Janie is a very healthy woman. And Janie, you should tell them your age, because you don't look your age. I mean, she is a very healthy, fit woman, and she is the epitome of what a donor is. Because the younger people, we're scared to death that we have no idea. We have to look into a crystal ball for our younger people to try and figure out what their risk factors are going to be for the rest of their life. Are they going to take care of their body? I mean, me at 20 is totally different than what I am at almost 50. Like, I want to trust that older person, this is where donation's on your side, because we know how well you've treated your body the first half of your life. As a donor, we're going to trust that you treat your body well the second half of your life. So donors are really healthy. It's a very exclusive club that even I can join.
So Janie, our listeners can't see you, but we do have your bio. Will go up on our website, so they will be able to see your profile picture. So would you want to share your age?
I usually don't, but I will. I just turned 64. So I'm going to retire in 3 months.
Congratulations. That's amazing.
So your recipient, you said, is the same age. So she's also around 64?
She's going to be 64 in August. Yeah. I'm just a few months older than her.
Is Maddie the kidney also going to, hopefully she doesn't retire anytime soon, right?
No. No, and my kidney is going gangbusters. My remaining kidney is taking up the slack.
Yes.
And there's a common question we ask donors, like that first, after they've been home and come back to see us a week later after surgery. If you had another kidney, would you do this again? And Janie, you can answer that one.
Yeah, if I'd like to be able to grow one back, and then I would do it every year.
Janie, what was your immediate, just because we hopefully are going to get some listeners who are curious about donating, what was your immediate recovery like?
So honestly, I was in the hospital for 2 nights. And then when I got home, all I took was Tylenol. I didn't take they gave me a big bottle of hydrocodone, whatever it is. I never opened it. I never took one. I just took Tylenol. And you say to people, it's kind of like having a baby. My first was a cesarean. It's kind of like having a baby, but you don't have to get up in the night and change diapers and breastfeed. You can actually recover. So it really, 4 weeks afterwards, I got on a plane and went to Arizona, and I was completely feeling normal.
Oh my goodness, that quickly?
Yes.
Wow.
Oh, yes. And I was hiking up in my neighborhood after about a week, doing a mile hike.
Oh my goodness.
Up and down. Yeah.
Do you have any parting comments?
Donate your kidney. We'll take it. No, I don't. I love my job. Donors are very special to me because they do something that I can't do, and they are doing something that's truly, truly selfless to help someone else out. And not everybody would do that. I run into a lot of people that tell me, I don't know if I could give a kidney, so to me, working with donors it's the first time in my career that I've actually worked with a healthy individual. I've been a nurse for, 25, 26 years, and I've worked with very ill people. First time in my life, I got to work with healthy individuals like Janie. Janie is my donor. And I feel very blessed to know them, because they are definitely, donors are an individual that you don't come across every day. They want to give their blood. They want to give their kidney. They'll give you the shirt off their back. And I feel very lucky to be able to take care of them and be a part of it and be a small part of their journey. So thank you so much before my phone dies.
Okay.
All right. Bye-bye.
Bye.
Anything else any of you guys want to add?
I would add that when people want to think about being a living kidney donor or any liver donor, they don't pay for any of the testing that we put them through, and the surgery and seeing our doctors and the social worker and the dietitian. They don't pay for any of that. It's all on the transplant center. We eventually bill the recipient insurance, but donors don't pay for anything. I think, they're giving their time, and they're giving up days to be evaluated. So, and the ones that fly out here that come across the United States to give to someone, there's like one health insurance, Kaiser, that will reimburse for flight, hotel, per diem. It's amazing. And then there is another resource out there called NELDAC. It's the National Living Donor Assistance kind of program. It's out there on the web too, NLDAC, NELDAC. And they will also try to, people can apply for that. And if they meet the criteria, get reimbursement for doing the same kind of thing, coming out, staying, flight, and some work reimbursement if they can't take vacation time off. And then the National Kidney Registry, that we're going to be having our living donors that want to be a part of the exchange, they also will reimburse people for taking the time to do this, take time off from work. I mean, there's a limit, but it's huge. So that's good. That's good news too. And the coolest thing is that poor little kidney that's in the body going, help me, my partner left, and I'm trying to clean the blood and handle the blood pressure. Human growth hormone gets released from our brains, goes down to the kidney and helps it grow. And so people get about 35% back versus the 50% of the other kidney they just gave away.
I was just going to say, I used to tell people, the kidneys are kind of lazy because they have a partner, but once they realize they're alone, they pick up the slack.
Yeah.
So my final words for any listener is, please don't believe all of these shows and these movies about transplant and donation. I don't know why they don't seek expert opinion, but they are very rarely correct. And if they are correct, it's usually like 1 out of the 5 things that they're doing. So please, please, please don't believe that. And check out unos.org because it's kind of a fun site.
And the National Kidney Foundation, tons of information too for recipients and living donors to learn all about this process and what it is, and answers so many questions. It's geared for the public.
Yeah. And the Living Donors Online is pretty good too, right? For all donors.
Yeah.
Yeah. And then, of course, Donate Life America is a great site for the public. And it's Donate Life Month, isn't it?
It's National Donor Awareness Month.
Okay, so you guys gave us good resources. You gave us good information. Janie, love your story. You guys, this was fun.
Thank you.
I was just looking for my transplant center pet calendar, which I can't find here at my home office. But my dog Leilani is a yellow Labrador, and she was wearing this T-shirt because we had to submit photos of our pets to go in the calendar and they get voted on. So I dressed Leilani in my T-shirt. She's a yellow lab, and she won, and she's the April calendar girl.
Oh, that's awesome.
Oh, you know what? If you find it, could you send it? We'll put it up on our Facebook page and our Instagram page.
Yeah,
I'd love to have that
please.
picture up.
So I don't know about you, but listening to Jamie, Janie, Kimber, Nettie, Steph, everybody, I actually want to donate a kidney if I could. And when I don't have the responsibilities of little children running around that I can't recuperate properly, I am totally open to seeing if I could donate. And I never thought I would do that. When we first talked to Jamie, I never thought I would think that, but after talking to all of them, I see the importance of it.
It is. And it's such a tremendous gift that you can give as a living donor. And like Nettie mentioned, the difference in the longevity of the success rate of a kidney transplant when it comes from a living donor versus a deceased donor is tremendous. I mean, a full decade difference.
So, anyways, I hope y'all enjoyed us talking to everybody about it. It's a bit of a longer episode, but I think it's so important, especially with tomorrow being what it is. So even if you don't want to, just at least spread the word that there are people out there who are in need.
And actually, I kind of want to make this be our ask at the end of this episode. Share this episode, please, with everybody. And, if you don't...
Let's get Jamie a kidney.
Let's get Jamie a freaking kidney.
Let's get Jamie a kidney.
You guys, she is the sweetest person, 35-year-old. I mean, not that anyone who's
and
not
a
any
teacher.
of this. A teacher. She's helping our youth. But she really is. She's one of the sweetest, funniest people there is. And I'm not saying, even if you're a rotten person and you need a kidney transplant, you still need a kidney transplant. You deserve a kidney transplant. But go to our website. You can see her bio. You can see a little bit of the information about her and her picture. So you kind of get an idea of who this is going for. But yeah, let's
and if she's published her Facebook page, we'll link it to ours too. Not like her private personal one, but her.
Yes, she has. All My Kidneys is up and running.
Oh, is it? Okay.
It is.
Fantastic.
And
okay.
Yes, absolutely. That's going to be linked in our website, which is anothersituationpodcast.com. And once again, you can find the bios and pictures of all of our guests. We're going to have our 4 experts that we also spoke with on this episode. They will be listed there as well. And let's get Jamie a kidney. And
let's get Jamie a kidney.
Let's set another record. I can't remember if it's now I'm not even going to guess. However many years in a row, it has been record setting for the amount of organ donations that have happened in the United States. So
really?
Yes, every year.
Even with like COVID?
Yeah, it's I did read, I can't.
That's fine. No, it's fine.
No, I want to say 6, 7, 8, or 11 year in a row.
Don't quote Ingrid on anything either.
This is a very unreliable podcast.
It's probably 93.7% truth.
And that's because of our guests.
We are that 6.3%. Anyways, let's get Jamie a kidney.
Let's close the gap on people who are dying every single day waiting for an organ. Be an organ donor on your driver's license. They're not going to chase you down. They're not going to not save your life in order to take your organs. So please share with everyone. April is Organ Donor Awareness Month. Let's do it, man. Come on, man.
Do
Can
it.
I say that? Come on, man.
Well, not when you say it like, I don't know. Sure.
Why not?
You're not that guy.
A couple other closing things. We forgot to mention in our previous episode number 15, the closing date for our giveaway on Dr. Ryan McNamara's autographed book. 2 of them. We are going to close that date April 12th. So you guys have one more week to follow the directions that are mentioned at the end of episode 15. Also, one more time, check out our website, anothersituationpodcast.com. You can find all of our episodes listed there. You can find links to any of our guests that were featured on those episodes, along with their bios and associated websites, emails, social media links, whatever they felt comfortable sharing. Those are all also there. And thank you, Jamie, Steph, Kimber, Janie, Nettie, for sharing your situations and information with us. Thank you guys all for listening. Thank any of you profusely. Thank you for sharing this, for checking out these websites. We are linking the EmeryLivingDonor.org on the podcast notes as well as our website. And if you want to consider being a donor for Jamie, her name is Jamie Sunderland, Sunderland. Her date of birth, again, is 6/24/1986. You need that information to plug in if you want to be considered to be one of her donors. Otherwise, if you are just looking to be a donor anywhere, go to unos.org.
And did we say Jamie's Facebook page is called All My Kidneys?
I think we did mention it, but it's good to mention it again.
Yeah. All right. Well, have a great day.
Yes. And how do they say goodbye in California?
Bye. They don't. Bye.
Bye.
If you'd like to reach out to us or submit your situation, please contact us at anothersituationpodcast@gmail.com or find us on Instagram at Another Situation Podcast. We're also on Facebook at Another Situation.
Another Situation is produced and edited by Point 5 Pinoy. Music is written and performed by Tim Crow.